how do we send them over to you all for, to go back, return to work?
Okay, thank you. I have to admit here that we do have challenges in the private sector for the return to work. What happens here in Malaysia, just talking about Malaysian scenario, where our occupational health in the private sector is not well developed. Most of the industries, they have their panel, general practitioners. And many of the general practitioners are trained occupational health doctors. They probably don't work for the industry, but they are the panel doctors. So the industry can refer these cases or these patients or the workers to the panel clinic and seek the advice on return to work. Again, I have to mention here, return to work is best done in the workplace itself, in the industry, not in the clinic or hospital. So if the occupational doctor or the general practitioner is able to go to the industries or into the workplace, have to be there on the site, and that's where he can plan on the occupational or the return to work program that is in the private sector. Again, I have to say, it's not well developed yet here in Malaysia on the return to work. But I've seen many rehab specialists, they have taken over this role and they have helped the workers, including the occupational therapy. They have played this role where they have gone to the workplace and helped out with the workers to put them back to work, return to work program. Another organization which is involved return to work would be SOCSO. They have a lot of return to work programs for the workers. They have state-of-the-art hospital in Aikro, Malacca. So if you can refer these patients or workers to the hospital, I think that will be very, very helpful for now. Yeah.
I actually have questions regarding when the patients suffer from long-term side effects from the treatment, and they come forward and ask the primary doctor to help them to get OKU status. Who should be doing it for this kind of application to the government?
All right. In hospital, we have a department, kebajikan, kebajikan, social welfare. There's a department in every public sector hospital, and the OKU they have to apply. But before that, they have to seek the treating doctor. The treating doctor has to say that this is a permanent impairment. He's having a permanent impairment, which they already reached something known as MMI, is maximum medical improvement. He already reached that any other further treatment or surgical intervention will not improve his condition. So now he will be under the category of OKU. But there's a list of what they call the items or criteria they have to follow, and it will be given by the department, and they will. That the card will be given by the welfare department in the hospital moment. So that's where the OKU, which comes under the law.
Yes. Sorry. I have my question. I remember when I was working in the government, once in a while I became one of the members of the board for medical. So cancer patients who have been diagnosed stage 4. So automatically they can apply for invalidity. Is that an optional, or is that if let's say patients doesn't want to be, or is it mandatory that they're going to be invalid?
I understand the invalid means the ILAT, right?
Yes.
The pension, right? The monthly pension, right? They are eligible for ILAT when the stage 4, the terminal stage of cancer, but the moment they have received that, they are not able to work at all. They cannot work. The moment they already received, have been approved to get ILAT. So there are some patients or workers, they feel that they don't want that ILAT part of it. They don't want the pension, and they still want to contribute. They still want to work. Maybe they have, because the ILAT they're going to get is very, very minimal. So they prefer to work. So when they, because of the responsibility, or they have their commitment, being a great soul winner, so sole breadwinner for the family and all that, so they need to work. So they will, they refuse to take the ILAT part of it. But again, the terminal stage or stage 4, it's going to be very difficult for them to work. So we usually advise them to go for that, for the ILAT part of it.
But with the advancement in treatment, there are so many patients with stage 4 who are no more. I think even it's derogatory to call it as invalid, because there are so many people who live long, they want to work. So my question is, they have the option to, so I think also maybe from my point of view, we shouldn't be recommending if the patients can do it, because they all have full functional capabilities, a lot of them. So that's my take.
Any questions from audience?
Hello, my name is Ruby. I'm a social worker. So I have a question here to Prof. Nirmala. For example, when a patient tells you that she comes from afar and she cannot attend to the next appointment due to cost issue. So what is your next course of step? What do you advise her? And secondly, if a person cannot work, she is only a breast cancer stage 2, but she just cannot work anymore. Yeah. So normally, how would she proceed on? Because she finds that being employed in private sector should be out any moment. So she clings onto the job in spite of all the physical pain. That's my question.
Thank you. You have brought up you opened a very important point that I did not speak about in my talk just now. I think because when I said we, sometimes it's not necessarily the physician, but the health system as a whole. So one of the things that, for instance, WHO has endorsed is patient navigation. And patient navigation has been something that is widely being implemented in the area of breast cancer, but I think it's just concept. So it can go to all cancers, it can go to all disease areas. And we are slowly piloting patient navigation services in hospitals, in public hospitals, but very limited because now we are starting with breast cancer. But I think it's something that is going to become mainstream, hopefully in the coming years. And this is exactly the kind of task that patient navigators are supposed to do. And patient navigation, I think, as is in many parts of the world, it is a service, but there is no job scope yet. At least in Malaysia and many other low and middle income countries, meaning that you get a personnel to do it. It can be a social worker, usually it's nurses who are trained, but the whole idea is there's a proper structured training. And they do exactly this sort of job, like in between questions. So not necessarily only physical related, but it's all related to, like working, any other needs that they have, social needs that I was talking about. So the patient navigator will help to adjust the appointments so that many of the appointments can be on the same day. Like now our patients come one day for blood tests, another day for x-ray, another day for MRI, like whatever, everything is not streamlined. So I think, and talking about streamline, we actually don't need patient navigators even for streamlining, especially in hospitals with digital, medical, where we do digital records, patient records, right? Because then you can use AI to bundle. You don't have to have that nurse checking and saying that, can I put everything together? But these are things which are very theoretical that has not been absorbed. So there are a lot of low-lying, low-hanging fruits that can be done. Patient navigation is an answer. But as a first step, you ask me what people need to do. I think we need to educate our young physicians, young healthcare professionals to hear out patients and not getting angry with them. Because these are very, very usual kind of requests we get from patients. And depending on the mood of the day, sometimes it gets entertained and sometimes it doesn't. But if we train everyone to hear patients, then I think we can be, at least until we get a systemic solution. And patient navigation is a systemic solution.
Very good.
This question is to Prof. Nirmala. I'm from Siva, from Center for Health Economic Research in NIH. So I just want to say that your findings is consistent with our similar evaluation that we did for cancer patient. And I saw that your recommendation was on PECA B40. We actually did the evaluation of PECA B40 program, and we did see that there was a lot of challenge. The problem itself introduced a lot of barriers which prevented patients from accessing the incentive for travel and transport. The other project that we are currently doing is on decentralization. So my question is that before we think about it, what do you think that we can do to push for policies on decentralization? Because this problem has been existing quite for some time, but we are still slow to take action. So what sort of evidences do you think that we can take in to push for that decentralization?
Decentralization can remain as a lip service because we can say it for very, very long, but it must be paired with equipping the people in the community and primary care especially with not only with the skills that's needed, because pain management, palliative care, supportive care, you require training. It's not something that, so of course from a very upstream level, our curriculum should be implementing and should be evaluating this sort of stuff. But we need to train our people in primary care, but it's not only training. So we have done some, some sort of research for palliative care on how do we build our primary care and community. So a lot of things is even in terms of awareness, especially like private primary care. They feel that, things like supportive care and palliative care is a hospital-based domain, because the way we have trained our students in medical school, in postgraduate education. So I think we need to do task shifting, meaning that you must have every hospital, you must be speaking to the people on the ground and leveraging. So you need to do a lot of needs assessment, not only from the level, from patients' side, but also from healthcare providers' side to see what is needed, what's missing. So in the instance of palliative care, there are a lot of audit tools which are developed internationally. The audit tools to specially evaluate is the primary care ready to deliver palliative care. So likewise, there are many, many other things that we need to do. So you need to prepare the task force. Because you can say decentralize, everybody go to primary care, but primary care is dying already in clinical kesihatan. You're doing so many things, right? So you need resources, you need training. If you don't provide that, of course in the beginning it's going to be costly, because we are going to, but the times that we reduce the people who are dying in the hospital, we do not, a good system does not let patients with chronic disease die in the hospital. I think it's as simple as that. So we need to make sure that, everything is in place before we say go to clinic kesihatan, go to primary care. So we need to listen to our GPs. So there are a lot of multi-level things that can be done, potentially at lower cost than just getting more machines, more drugs, more everything. So that sort of work is more health systems, and it doesn't sit either in epidemiology, in clinical trial. Sometimes the kind of research that need to do, the methodology, we have to figure out ourselves. So sometimes you just have to figure out, but those are the things that will fill up the jigsaw.
Hi, I'm Kamalia, a GP. I have two questions. My first question is for Dr. Abdul Razak. So based on your personal experience, how long did your leukemia treatment and recovery prevent you from working as a doctor? And then, as government doctor at that time, with access to GL, did the illness affect you financially during that period? If yes, due to what kind of hidden cost? If you don't mind answering. Okay, number two, for Dr. Gogillan, when you say when the patient claim the ILAT benefit, the patient cannot go to work anymore, that means cannot get employment. Is it just employment that related to SOCSO or any type of employment? If it's like contract basis, doesn't have SOCSO, is it allowed or how?
I don't mind. I don't mind answering. I mean, it sounds more personal, but I think you can learn from my personal experience. Like I told you, CML is effectively treated with tyrosine kinase inhibitor or targeted therapy. Within a month, my blood count was back to normal. I feel, almost back to normal, and that time I was MC not more than a month. But the most painful part, which was during my transplant, which needs longer recovery time. So even then, I'm back to work, within less than 6 months. I think probably around 5 months plus. But of course, I started slow. I wasn't been advised to treat clinical. I just do some administrative works in the office. And yeah, then slowly I'll go back to full work. So it's basically less than 6 months. In terms of financial burden, GL of course it's been covered, but at that time in 2006, targeted therapy has not been, this particular medication has not been approved by the KKM. So luckily there was access programs that everyone can get access to. Of course, the initial part was covered by JPA. I can do claims because average Malaysian, they have to spend about 8,000 a month for targeted therapy. I think you all know that therapy is very expensive, only for a few months. Then I suppose JPA noticed that, oh, this is going to be a long life treatment. So they cannot afford to pay me reimburse me 8,000 a month, every month until indefinitely. So I was referred back to the access programs. Of course, the access program needs some interviews to see your financing status. So even I'm a doctor myself, 8,000 and in government, even in private, I still cannot. So I think for an average Malaysian, 8,000 is still very expensive. So luckily there was an access program. So I wasn't been too much burdened in terms of that things.
Right, yeah, the second question, right? ILAT, you're right. ILAT also known as invalidity pension given to the workers. There are certain criteria they have to fulfill to get ILAT. Right, the moment upon receiving ILAT, that means approved ILAT, they're not able to do any kind of job. Even if they're found to sell some kuih or nasi lemak and all that, they can be blacklisted by SOCSO. I think you all heard certain fraud has taken place recently involving SOCSO, which actually recently I attended a conference on that, on the fraud and all that. These are given to those who are not able to work at all means, including even online. That means they're not supposed to get any kind of income from their own business and all that. Okay, if they're found, then it will be blacklisted and the thing will be withdrawn.
Meaning they cannot be business owner also?
No, that means they're getting some income. The moment they're getting income, there will be no pension due. Right? So they should be just depending on the pension. So I've seen people have heard cases where they get pension, invalidity pension, and they do Grab driving, this part-time job and all that. Which is not accepted by SOCSO. And SOCSO has their own eyes or spy and all that, where they will trace. And if you're found to do all this and getting money, because they're already getting money from SOCSO and all that, then they say, fine, you'll stop this pension, you continue with your work. So it doesn't matter whether the work is part of the SOCSO thing or their whatever type of job, as long as it gives them an additional revenue or income, it's not accepted. Okay, got it. Thank you.
Thank you. I'm Shakir. I really resonate with what Prof. Nirmala said earlier, that patient navigation is the way forward, and it is very important in many ways, especially in addressing financial toxicity and many other things. So I believe this is not only isolated towards cancer ecosystem. So I have spoken to the rare disease community as well as TB, surprisingly. So there has been lots of issue that has to do with therapy adherence, which is very detrimental to the outcomes, living outcomes of the patients and community. So many of the reasons, more often than not, is financial toxicity. So with regards to going back to the patient navigation program, do you see that it can be extended towards beyond cancer community, and if so, what are the potential framework that perhaps we can begin to further spark further normalization of establishment of patient navigation programs?
Thank you for the question. I am a big supporter and even a person who is actually actively involved in trying to develop patient navigation beyond just cancer and beyond just navigating, because the birth of patient navigation has got to do a lot with the fact that when people have symptoms, there's a disconnect with diagnosis, and when they are diagnosed, there's a disconnect with treatment, and when they get started with treatment, there's a disconnect with continuation of treatment. So there's treatment abandonment. So everything is very clinical. Patient navigation started to fulfill clinical purposes. And then when people started realizing that patients have a lot of clinical problems because of their social problems, then it expanded. But then now we are at a crossroad where financial problems itself, toxicity itself becomes a big problem. That patient navigation curriculum, because remember I said that patient navigation is a structured training. So a lot of the training, because they have to cover so many domains, financial navigation is very brief. So in fact, financial navigation in itself is a service. So we are only at the juncture where I am trying with our group, we are trying to develop financial navigation services to be put back into patient navigation to prove its worth. And we need a home to prove its worth. So we are putting it in cancer as a home so that you can show that it works. I think cancer makes it work even faster and a bigger impact than any other disease, so it's easy to take, and then we say, so we are very, I think it's in infancy stage. So if we prove all this, then you get a buy-in from the system. So I can go back to patient navigation and say that many years ago, when Professor Teo Suwang was very much interested in studying patient navigation, it was a research kind of context. This is like when I just finished my PhD and came back, and she was like starting, and CRM took it on, and they proved, and then it took so many years now for MOH to accept that patient navigation is a strategy that should be inside our Ministry of Health in our National Cancer Control Policy. So you see how long it takes, right? So now I'm saying that for the past 5 years, I'm saying patient navigation is enough, we need financial navigation. And this is another slow step, because when we are doing it as research, we need funding. So when we prove that, then you will have the health system buying the idea. So once the health system buys the idea, then you get everybody. So it is a very slow step, but not only in Malaysia, but I think this is the story for everywhere. And what helps is if you have backup from large organizations like WHO, UICC, where they come in and say, yes, this is important, then governments listen as well. So you need evidence, local evidence, you need that international stewardship, and you put all that together, and then of course we can move on. But once the idea is proven to work, we need to prove, unfortunately. Everybody say, obviously it helps, but you need still to provide some numbers for the policymakers, because we do not want heavy reliance on NGOs. Patient navigation right now relies heavily on NGOs. We need a top-down kind of funding, fiscal support from the government, and for that, we need to do all that we are doing right now. So I hope it's in infancy, but I'm seeing that we will get there someday, hopefully soon.
Thank you.
Thank you. Before we break off for lunch, I'd like to invite our speaker to give a mantra each to the audience. What is the best way to summarize your talk in just one sentence?
All right, thank you very much. Well, we know a cancer patient actually faces a lot of challenges when in his daily life, and that's the part where when he's at work, okay, there are many more issues that he will face. So that part is not being tapped yet. We have not actually have a good solution to help him out with that. So we hope that we all can work together and help a worker while they are at work after the treatment for cancer. Thank you.
For me, I think that this is beyond cancer. Healthcare needs just one side of the coin. The other side of the coin is health-related social needs. And if health systems are only focused on one side, we are missing the bigger picture. No matter how well we do, how much drugs we offer, the fanciest hospital will not be able to improve the overall well-being of the society.
Okay. Yeah. In summary, if any one of you involved directly or indirectly with patient support groups still struggling to sustain, just think back that we are not in an ideal world. Just think about what works for you at that moment of time. Okay.
Thank you very much for our speakers. And thank you. And shall we give a round of applause to our speakers for their wonderful talk? Thank you very much.
Okay, yes, thank you very much to all our speakers as well as our chairperson for the session, Prof.Chin. We would now like to proceed with a small token of appreciation ceremony